you have the bios on your handout. What we asked was for the speakers to tell us something about them that we didn't know and something about their country. So our first speaker is Dr. Osterbrink, and he is from Austria. And what he told me about himself is that he loves Wiener Schnitzel. How many of you have had Wiener Schnitzel? A few, okay. He said also that most people don't know that The Sound of Music was filmed in Salzburg, Austria, and he is a big fan. Maybe he'll sing one of the songs. Please help me welcome Dr. Osterbrink.
Dr. Christie, you're telling all the secrets. All the secrets. But anyway, good morning, everybody. And it's a privilege for me being here on the third floor. When I'm in Jacksonville, usually I'm on the second floor, having lunch. But until in the third floor, I've never been. Anyway, I would talk about an aspect of healthcare in Europe, and I try to depict palliative care as a topic. But before I'm doing this, I will a bit talk about Austria, and I realize that Dr. Robinson before wants to do it. Here in Austria, see here, 8.6 million people living in Austria, and it's surrounded by countries like Germany, France, Belgium, Switzerland, the Czech Republic. Austria, geographically wise, here you see Vienna, Salzburg, it's here. It's 9, Austria in total, 9 states. Salzburg is an own state, 520,000 people living there. And some impressions, if you were never there, this is a typical picture in May, and last year we were fortunate to a group of colleagues from the UNF in Salzburg for a couple of weeks, and I'm fortunate to say that it was not so bad to return next year, and thanks so much. Yeah, I will not sing famous song, I won't do it. But the Sound of Music, certainly, especially for foreigners, especially for Americans, seems to be one movie and one film everybody knows. If you were there is a grand guided tour for $20. Do it. It's absolutely nice doing it. So, the agenda for the next 25 minutes, I will talk about the development history of palliative care in Europe. I will focus on services, multi-professional services. I will focus on policies, which might be transferable also to your countries. I will talk a bit about professional teams and roles, because teams and roles sometimes are underestimated. And the qualification of palliative care, and I use, of course, Austria as an example, and some research results. And I will start with this young lady. I was responsible for this lady while she was in a hospice some years ago. And she asked me one evening, you know, I would like to have a drink. And I told her, what drink? Well, perhaps a glass of champagne. And I told her, I will join you. We will have now a glass of champagne. And we had a glass of champagne. The champagne was good, she was happy, I was happy. And this lady died the next morning. And exactly this is palliative care. Look at this lady. She looks happy, she looks awake, she looks pain-free. And I think everybody in this room who is either a nurse, a physician, social worker, or whatever, agrees this is a perfect sum of a multi-professional approach. And If I talk about palliative care in Europe, I have also to talk about that we are just at the beginning of our journey. There is no common development. There are different concepts in the European countries and regions. Because also we have no unified healthcare system, and we have diverse cultural backgrounds. We have no common language. We have differences among national approaches to palliative care, and we have a different understanding what's all about palliative care. And if we start about palliative care, we have to, first of all, agree that we have to look to history. And Dame Saunders was a nurse, a social worker, and a physician. And very seldom one person are nurses, social workers, and physicians in the same time. And that's why I think Dame Saunders has shown us this so precisely that it's important that all groups have to work together, have to have one plan for the patient in the palliative care setting. Either it's in hospitals or in hospices or in the outpatient area. She created a unit of care, and a unit of care in a hospital and in a hospice. UK is a model, important role of inpatient hospices. She developed a fundraising system, especially to the Macmillan Society, where easier for bricks and ideas, this was saying, and the importance of fundraising for independent, often freestanding services, which were nearly 80% founded by fundraising. And important is to combine our service and research. Often you only depict our service either as physician and or nurse, but important is also to have a very profound research setting and results. We often focus on cancer and cancer only, but have in mind that we are having an increasing number of patients suffering from multiple sclerosis, from Parkinson, and other diseases, which needs palliative care, especially in the last weeks of their lives. In Germany, with a delay in time, the first initiatives were founded in the mid-80s. We had a hospice movement and a palliative care movement, common Christian rules, especially the Roman Catholic churches were involved. And actually, these are figures from 2013, 80,000 volunteers are involved in the hospice work in Germany. Again, Germany, in the first years we had freestanding hospices led by nurses or social workers, and both groups worked very closely with family physicians and or palliative care specialists, especially in big cities. Now we're having hospice teams, which are also responsible for outpatient facilities. Germany developed curricula, and I will come later about training for physicians, for nurses predominantly, and there are some curricula also for spiritual carers. On the other hand, 2012, palliative care were translated to palliative medicine, with a strong focus on developing a medical society and sub-specialty. And this brought, especially in the German society, one step forward, that we were able to combine also research and services, especially in hospices, more closely. And palliative medicine is now, since 5 years, obligatory in the education of German physicians. If we see here this picture, you see palliative care is the foundation, and complication, symptom control, rehab, and care for the dying under the rule of quality of life is the leading model. The graded system of palliative care services, and here you will see an Austrian model, and I start left outside. You have the acute care setting in hospitals, long-term care, in nursing homes, and the home care led by GPs and community nursing teams. This was created, as you see here, in 2004, and it needs another 10 years that we were able in Austria to develop a research model about this more practical-based palliative care approach. The EAPC is the European Association of Palliative Care, we will see this in a second, is a non-governmental organization recognized by the Council of Europe, and that's why the EAPC works very closely also with the European Parliament. Was established in 88. Last year, it had for the first time individual members from 48 nations across the world. And as director of the WHO Collaborating Center, I was asked to develop, together with the EAPC, an international-based curriculum, which is good for all 48 nations as basis and basic curriculum, which I now will develop with the EAPC as well as with my colleagues in Salzburg. The mission is to foster the vision of excellence in palliative care that meets the needs of patients and also, very important, their families and the direct caregivers. That's why usually in palliative care we focus too much only on the patients and we forget sometimes the needs of the direct caregivers, the next of kin. And that's why research-wise we focus now on both groups, and I will show you in a minute some results of our research we have done in a German city. And to develop and promote palliative care in Europe through information, education, and research. And again, you see here, using multi-professional collaboration. And when we developed this mission statement, it was hard work, really hard work to integrate the multi-professional collaboration and the multi-professional approach, which was in 1996. But now I think we have a living mission and a living mission statement, and we see now, especially in the northern countries, Scandinavia, the UK, Holland, Netherlands, Philip Lurk will talk about in a minute, that we see, especially in these countries, that the multi-professional approach works really well. We have some work in the East European countries, especially in the New East European countries like Kyrgyzstan. But, well, we have to start in, especially in these countries, to develop a very stable multi-professional system, and we will begin next year to gain some research data. These are the EAPC members. But if we talk about terminology, we have not, due to cultural backgrounds and languages, a common terminology. We talk about palliative care, hospice care, supportive care, end-of-life care, turn-on care, and respite care. And this means palliative care. That's why we need to unify first our communication, develop then an approach, especially for our young carers, and afterwards, in my opinion, we can start to develop a system. Common values of palliative care in Europe, and this was also hard work developing this, is of course our autonomy. The autonomy of the patient, the autonomy of the families, and the autonomy of the direct caregivers. Dignity is another aspect. We, as nurses and physicians, are responsible to develop our service with dignity for the dying. And dignity also to have a clear understanding what our patients want from us in the last weeks while they are living. And the collaborative relationship between palliative care staff, patients, and their families is the key to performance. The best quality of life. Sometimes champagne is fine, and sometimes almost you need painkillers, almost you need a good respiratory care. Often you need to have a good bowel movement treatment, and. Means this has to be depicted by the direct caregivers and communicated by nurses to GPs or palliative care physicians. Holistic approach. Holistic means really to understand the life circle of a patient and also the direct needs. And the direct needs sometimes are difficult to depict. The interaction between patients, staff, families, often families are not willing or not able to understand the actual situation of the patient, and that's why effective communication is so important. Education, and education means continuous education, not having a degree or a certificate. Important is continuous education in one important field of our profession. Collaboration between different professions and loss of and mourning. And that's why if you are grieving, the combination of physicians, nurses, and spiritual carers are so important, especially during the time when the patient is dying. Different levels of PC, palliative care. The palliative care approach on the left side, you see that we use it in different settings and services. In hospitals, in nursing homes, in hospices, and in the outpatient facilities. And general palliative care might be provided by a non-specialist like general practitioner, as well as nurses with a training on a certificate level. And the centers of excellence are having an expertise in education, research, dissemination, and they are developing standards and methods, and they are using their knowledge, being a transmitter of their expertise, being multiplicators in these settings and working together also with colleagues in the various settings. The specialist palliative care colleague provides special training teams, physicians, nurses, social workers, spiritual carers, as well as developing highly qualified teams who are only focusing on palliative care as best case approach. And if I talk about norms, we need to have norms. Norms on a national level, and norms on regional and local levels. One fits all, and I always talk about the T-shirt method. The T-shirt method will not work. One fits all is impossible in palliative care, and that's why we have to develop on a national level a uniform strategy for development and control. And on a local level, we have to develop national norms, and they are adapted to the specific characteristics of the region and or institution for the direct caregivers, for the physicians, for the nurses. And the best results we have seen also through research we have done, Lukas Radbruch and myself, is a combination of both. But first of all, if I can say it frankly, it's important to have a national norm, and based on this we need regional specific characteristics. The aims of palliative care is to promote quality and reduce variation in the new and existing programs, develop and encourage continuity of care across setting. Often we see a breakdown of communication, especially if we combine hospice care and hospital care. And it seems, perhaps it's only an Austrian or German phenomenon, that a hospital physician and a hospital nurse is not able or willing to talk about their treatment with hospice nurses and or nurses working in nursing homes. To facilitate collaborative partnerships among palliative care programs, facilitate the development and continuous improvement of clinical palliative care programs, and establish accepted definitions of the essential elements. There was a task force working already in 2007 on the development of palliative care in Europe, which were led by Carlos Centeno from Spain and David Clark from England. The evaluation showed that some common structures, but also a wide variety in the structure of the service development and care delivery, due, and this is important, a different understanding on the underlying concept, one fits all problem, and a different understanding of the terms of palliative medicine, as I depicted earlier. And if I see this picture, if you don't see it clearly, I will explain it in detail. UK and Ireland are the countries with the best ratio service per million inhabitants, and this is added as an indicator. Importantly, we see here that in the UK and in Ireland, palliative care began due to the work from James Saunders. But all the European countries you see here, there is a long, long way to go until we reach the excellent service from the UK and from Ireland. There are some countries who are involved more closely to the work of Ireland and the UK. This is Italy, it's Hungary, it's Austria, and Germany. France developed actually mobile teams or hospital support teams which support the patient in the hospital, and when the patient is discharged going at home or directly to the hospice, the mobile team also follows the patient. And I think this is an excellent model that the patient has in the hospital and also in their situation while he's treated in a hospice. The direct carer, either a nurse or physician is still the same person. We are working very closely on pediatric palliative care, having the whole family and the dying child in our focus. We try to estimate palliative care beds for one whole nation. We try to certify palliative care as a specialization or sub-specialization. And we try also to have a bibliometric analysis on the national development of palliative care, and we communicate these results first of all to the various health ministers as well as to WHO. Our task force found that we have a diversity found in the types of services within different countries. We have a lack of unified standards. There is no standard of palliative care in whole Europe. There is perhaps a national standard, but perhaps means only in 4 European countries we have national standards. We have a lack of universal accepted definitions for each type of the available resource, and we have different interpretations of what was considered to be a specialized palliative care resource. Which means, again, we have a long way to go, but at least we know where our problems are. And if we understand our problems, we can develop strategy. And strategy was depicted in a white paper on standard and norms for hospice and palliative care in Europe. The aim is, first of all, to develop a common terminology and common quality norms. And we try that the EAPC present norms and working definitions, and we work them on a national level with our colleagues. And the consensus on norms seems now to be realistic. 10 years ago, absolutely unrealistic, and it was also no will between the different countries to work together. The key areas of norms are to have a common terminology, common language. We try to develop a collective value and philosophy, what's all about palliative care, the different levels of care, different group of patients, as well as a variety of services and differences of settings. Other areas like education for healthcare providers, documentation standards are until now not covered, but this will be our aim in the year 2017 forward. Which steps are needed and which challenges we have to face? First of all, to the politicians in the room, we need, of course, worldwide additional resources. But first of all, also, palliative care needs to become a priority of a national and European health policy development. And I'm brave enough to say we need to have a world health policy development. And in the upcoming World Health Assembly, which will be in Geneva in 3 months, we discuss especially this aspect that we need to have a worldwide understanding what it's all about if we talk about palliative care. And this can then, if we know what is a priority, we are able to develop national strategies and plans to cover the individual demand, and then we are able to have a precise understanding of the needs of the dying and as well of their families. The basic requirements are, of course, an advanced care planning, and nurses are here in the very privileged situation that we know, in my opinion, as a nurse, I know exactly the needs of the patient, either if he or she is treated in the hospital, in the hospice, in the nursing home, or at home. But importantly also is to communicate my results directly with the GP and or to the palliative care specialist. This means them to being able to provide a continuity of care in trajectory and of course also across settings. And this means then also to have a perfect timing in the delivery of our services. And I will depict now some results of a research project I've done for 5 years. I try to analyze the pain situation in one whole city. Action Alliance Pain-Free City, the city was Münster in Germany. We analyze all hospitals. We focus on acute postoperative pain. All nursing homes, we focus on chronic and acute pain. We focus on outpatient care here on cancer pain, both pain centers. We informed local residents and we trained GPs and educated also pain nurses. In hospices, there are 2 hospices in this town. We focus, of course, on cancer pain. And if we thought that pain and cancer pain and palliative care in one small city, again 300,000 people, is easy, I know now it's not easy, and I will show you why. There is a desire, and here, first of all, I depict some perspective of the involved nurses. There is a desire for change, to integrate more non-pharmacological treatment option. And there is a desire of change also to increase the pain assessment, especially for those patients who are suffering from cognitive deficits. And nurses see a significance of pain for the patient and the integration of hospice in the municipal care system, and the positive rating of hospice care was certainly done by patient and caregivers. We have various problems you see here, and we try to overcome this. The pain assessment in patients who are not able to express themselves verbally was difficult. We solved it. The critical statements of nurses with regard to tool-based pain assessment, the existing versions are not sufficient for hospices. Yes, that's why we developed also instruments that we were able to assess pain in this sub-patient group, that we were able to communicate sufficiently with the GPs. Difficulties of some patients to adequately report pain. The pain assessment of nurses is influenced by how well they can bear the patient bearing pain, and so on. The pharmacological therapy, difficulty of pharmacological pain therapy, if it's unclear whether the patient has psychological or physical pain, emotional pain or physical pain. And the significance of pain for hospice patients, the patients are afraid of future pain, even if the current pain situation is satisfied. That's why we have to have the holistic view. We have to have a system which unifies all 3 groups: physicians, nurses, spiritual carers. The experience of patient made in the past and the resulting influence on the present pain experience. That's why it's so important in hospices to have nurses who said, I'm here for you. And that's it. I'm responsible for you within the next days. For some patients, it's important to feel the disease in the pain, and therefore they decide against pain therapy. This is also important, but we have to know it, we have to communicate it, and we have to discuss it also with the patient as well as with the GPs. Hospice care is a relieving function of hospices for patient and calming effect of the hospice for patient. The central results for hospice patients interviews, we interviewed in total 25 patients. The interview lasts from 5 minutes until 20 minutes. These are no interviews which last for hours because of the situation of the patient. Coping with the disease means a negative experience in dealing with the disease in other institutions, mostly hospitals. Spiritual support by spiritual carers, here pastors. Differences in dealing with the disease on the part of primary care physicians and difficulty to dealing with the disease. And here's one result of Mr. or Mrs. L.E. And he or she said, well, I must say that I felt was in a really bad condition in the clinic. But the stay in the clinic was aggravating. Yes, I don't know how I deserved it, and so on. And again, you see here, I did not get the galleries. The mattress was very hard, and so second, I could not actually feel every single vertebral body. And nobody asked her how she or she was feeling. And the pain experience in the hospice was pain occurs in different situations, in different areas of the body, of course. Pain is sufficiently reduced in the hospice. Pain therapy enables a self-determined organization of the day, and pain therapy is ensured by a better attitude of the staff. It's being considered very, very much. They are not 1 minute late. You can set the clock on it. When it knocks on the door, I know my medication is coming. This results in ease of mind and calmness. Then we also have regular visitors that can come to me at all the time around the clock. This is important. Being there and being responsible. I don't feel like being in a hospice. It feels as if I was going to bed. This is important. This is important to increase autonomy, to increase well-being, to increase activities of daily living, especially also in the last days, even the last hours while you are living. The future in palliative care, 50% increase in cancer incidence until 2030. 2010, 450,000 new cancer patients. The increase in chronic diseases and comorbidities, heart, kidney, brain. 2030, approximately 2 million people with dementia alone in Germany. 2010, 1.1 million. Due to advances in medicine, lucky enough, we will live longer, but it leaves patients with a longer time with disability. Every medal has two sides, and this is the downside. In the UK, man lives 14.7 and women nearly 17 years with a poor health status. And we have to be aware, absolutely aware, that we need solutions. Otherwise, we were not able to provide a good care from a nursing point of view and or from the view of a physician. And we have an increased financial burden to the healthcare system and their families. And that's why it's so important that we have a clear terminology, that we have a clear solution on a national and international level. And we have to be clear, crystal clear, that palliative care is a human right. A human right, this we will discuss on the ERPC conference in Prague next month. And again, this lady with her glass of champagne. Everybody of you here in this room is able to give good nursing care or good care from a viewpoint of a physician. You have the knowledge, you have the technology, just do it. Thank you very much.
Found any problems with cultural differences amongst all the European countries on how they view palliative care?
Cultural diversity is your question? Of course. Even within Germany. If you are living in the north part of Germany, close to the Danish border, you have different values than compared to the patient living in Bavaria. But if you see then West European countries, South European countries, East European countries, you have to have always the culture in mind. And if you have the culture in mind, you are able also to create the good nursing care. If you are not understanding the culture for whatever reason, or if you don't respect the culture, you are not able to provide good nursing care or good care from the viewpoint of a physician. This, I think, is very important, but not only in palliative care, but especially in palliative.
Most of the services have in the hospitals or nursing homes or the patient homes.
Yeah, there is a major difference. If you open the door in a hospital, there are always nurses and physicians there. In the home care setting, the problem with the home care setting is that you are predominantly alone, mostly with your loved ones. And that's why it's so important to have a perfect combination of and communication of GPs, nurses, and you have to have also a good technology. We developed, for instance, with our knowledge from the project of the city in Münster, a pain app. And the pain app was developed directly afterwards when we completed this project. The nurse and or the patient rates of the pain, the quality of life, the activities of daily living. It's important also to combine our research-based knowledge in developing new systems. There are 300,000 patients in this country are dying because of bad hand hygiene. These are important figures. Nobody talks about bad hand hygiene. And this is very similar here to palliative care. Because palliative care patients and their families has no lobby. And if you are in the status of grieving, you are not able to say, we had a problem while we are treating my husband or my father. And when the grieving process is completed, usually you say, well, it was okay during this time. Means we have a sincere problem worldwide. But now we have to also focus on this problem. One aspect is hand hygiene, worldwide, not only here. It's a worldwide issue. We know since Florence Nightingale, or since Dr. Lister from Glasgow, or Friedrich Semmelweis from Austria, and they are all since a long time dead, that we know we have a problem in handling. And we know also from Dame Cicely Saunders, yes, we have a problem in palliative care, but now we know, let us set up standards. Don't see problems, see solutions. And one solution is, of course, we develop a standard, and that's why I see a very profound move now in the hospice movement worldwide, especially in the Western European countries. Does this answer your question? You can say also no.
No, I think maybe I have a friend who lives who's from Paris,
Okay.
and the attitude, maybe it's the culture of nursing that they feel he looks down on nursing, and I think maybe because the people in Europe don't look at nursing or healthcare as a priority or something that is needed, maybe that has influenced the negativity of your priority.
Absolutely. Sir, 2 meters tall, which means 6.6. And I'm proud to be a nurse. And I'm also proud to say that this will be WHO priority in the future. And it makes absolutely no difference if you're working as physician, as nurse, or as spiritual carer. Only one aspect counts, and this is good care in the last weeks of your life. And this is important. And you are absolutely right, there is some miles to go. But everybody now, and I see this European movement, everybody now is on the way, and everybody is happy to go this extra mile. Yes, sir.
Yeah, by the way, I think your pain-free city is a great concept, okay? What year did you have the intervention? And then have you tested it recently? And thirdly, is anybody else in Germany going to do this? Are you going to export this in any way, do you think, down the road?
Well, this was not one question, this was 4 questions. I will answer your last one. Well, Münster was just a role model, and I'm also happy to say that WHO gave us the best practice model 3 months ago for our project in Münster. And yes, sir, we will export our results to 3 different cities in Germany. We will export this to 1 city in Austria, the city is Linz. And we will, there were 2 Scandinavian cities who want to learn from our project. Question number 2 was, here the answer, yes, we tested and retested it, especially in the setting of hospitals. We certified also structure, process, and outcome criteria. This after 2 years, and we will have a post hoc testing in the year 2018. And to answer your question number 3, yes, we have funding also for this intervention. And number 3 and 4 was a combined question. We tried also to have a focus on various healthcare settings. This was difficult. Difficult to combine nursing homes, hospices, rehab centers, hospitals, and outpatient facilities. And it was also difficult also to reunify nurses and physicians and spiritual carers. But you need a long breath. But finally, it works. 4 questions. 4.
Good.